So we're going to go ahead and move forward to the next talk here. I'm Dr. Jacqueline Nicholas, and I am the System Chief of MS here at Ohio Health. And I'm excited to talk to all of you about some of the emerging MS therapies that are under study and current research. I know this is a common topic that many of my patients ask about when they come in, and really what I'm hoping to run through is high level in the short amount of time today, just some of the top of mind interesting therapy options that we're looking at currently. So again, just as a reminder, feel free throughout the talks today to shoot any questions that you have about anything that's been presented so far or about MS in general, and we're happy to answer that for you. So here's the outline of what we're going to talk about. Some of you earlier heard about Dr. Eubank talking about BTK inhibitors. So I'm going to go into a little more depth on that. We're going to talk about stem cell therapy in MS, which has certainly been a hot topic for quite some time and something that I think many of you would be interested to hear. We're going to talk about a new therapy being looked at for remyelination and repair in multiple sclerosis. And believe it or not, it's actually gold, so that's pretty neat. And then an update on some studies looking at ocrelizumab, which is certainly one of our current FDA-approved therapies for both relapsing and progressive MS, but something that I think will be relevant to many of you out there. So let's talk a little bit. What is a BTK inhibitor? So this is a class of medications that actually has been around for quite some time and used more in the cancer world. But as many therapies that have come about for MS, this type of therapy, over time, researchers and physicians within the world of MS started to think, why wouldn't this work in MS? We know that many of our therapies in MS target B cells. B cells are one of our white blood cells that really starts the fight or the inflammation in MS. They often identify parts of foreign invaders and then actually can produce antibodies to go out and call in other immune cells to come and cause attack or damage to that myelin sheath on the neurons. And so BTK inhibitors can actually reduce those B cells from getting overly excited. And so that's certainly an area of interest. And then also, we have a certain type of cell within our brain and spinal cord, it's the central nervous system, called microglia. And microglia have long been thought to be part of the reason that we see progression in multiple sclerosis. And so I'm going to get into that a little bit more and about really what these cells do and what they are and why we want to inhibit their activity with this type of medicine. So please ignore the complexity of these pictures, but what I wanted to show you is that both B cells and microglia within the central nervous system are activated through complicated pathways. And that activation can lead to damage and inflammation in MS. You can see on the left-hand side of your screen that when we look at B cells, again, we talked about the antibody production and cytokine secretion. Cytokines are chemicals that help to signal other white blood cells to come in and cause damage in MS. And that's why we have found that therapies, for instance, like ocrelizumab or ofatumumab, both of which deplete B cells, are very highly effective in MS. And then microglia, these are what we refer to them as resident macrophages within the central nervous system. And macrophages are a type of cell that really are scavengers, and they sort of eat up debris and get rid of things that don't need to be there. These have been implicated in inflammatory cytokine secretion, so again, releasing signals that lead to more inflammation. And they've been long thought to result in damage to neurons over time when there's chronic inflammation. And this can lead to dying off of neurons, which can lead to progression or gradual worsening of physical function in multiple sclerosis. So what I've walked you through here is how B cells and also microglia can play a role in MS. What you'll notice is that red circle there, BTK, that stands for Bruton's tyrosine kinase. If we inhibit that enzyme, we actually can inhibit all of the downstream effects, or many of them at least, with the B cells and the microglia. But the neat thing is we're not actually destroying these cells, because these cells do have some important roles. One of the things that we've run into with chronic use of our B cell depletion therapies, or treatments for MS that essentially destroy B cells, is that we run the risk of increased infections over time, mainly urinary tract, but also upper respiratory infections. And so we, in the world of MS, have thought about maybe there's a way that we could alter the activity of B cells without actually destroying B cells. And so one of the hopes and thoughts with BTK inhibitors in MS is that perhaps these will be highly effective therapies for MS, but maybe with added safety where perhaps we aren't going to see as much in the way of infection. So again, studies are underway, and we hope to be able to better understand that. The picture on this slide here really shows you what's happening inside an individual's body when they have MS. So you can see on the far left-hand side of the screen, that's your peripheral bloodstream. So we have white blood cells. The main ones that we talk about are the B and T cells. And those, when they see a foreign invader in the setting of MS, we tend to think that the trigger is a virus called Epstein-Barr virus, and that virus, when somebody is infected with it, our immune cells may see that and mistakenly think that it looks similar to myelin. And then those immune cells in our body start randomly attacking our own myelin in our brain and spinal cord randomly, and that can lead to certainly significant neurologic damage over time. And so when this happens in the periphery, then these white blood cells can sneak through that blood-brain barrier. Typically in the setting of in people who don't have multiple sclerosis, we're not seeing those white cells sneak through the blood-brain barrier to the same degree. Then within the central nervous system, there are certainly many different immune cells involved that lead to further inflammation, what we call neurodegeneration, or slow dying off of neurons, as well as the demyelination. Now, if you look at the right-hand side of the screen, this is a picture of what we saw in the prior slide. We were talking about that cell called microglia. These, again, are really the scavengers. So back when I was in undergraduate school, I remember my immunology teacher drawing pictures of cells or circles with teeth and referred to them as the slavering macrophages, and they would sort of eat up that damage and debris. Well, if you see in this far right-hand picture here, this microglia is sort of just enwrapping this myelin coating on a neuron. And in MS, we've started to realize that it's not just the fact that people get new lesions over time, but they have these deep, chronic white matter lesions where we can have damage happening even after the lesion has been there for quite some time. And that leads to the slow dying off of neurons, and we want to figure out how to get to the bottom of that so we can perhaps delay or prevent progression. And so this is just another facet of what we hope BTK inhibitors will do. I wanted to outline for you, currently there are 4 main BTK inhibitors that are under study. Here at Ohio Health, we're actually involved with 2 of these. Tolebrutinib is a BTK inhibitor that is currently in phase 3 studies, so end stage clinical trials, which is very exciting. And we are actually running the trial in primary progressive MS, so it's being compared against standard of care ocrelizumab, and we're very excited to be a part of that. There is also a study looking at a medication called Tolebrutinib, which is a different type of BTK inhibitor. And this one's also in phase 3 studies and also looking at relapsing MS, primary progressive MS, as well as what we call non-active SPMS, or secondary progressive. So you heard Dr. Eubank talk about progressive MS earlier. Non-active SPMS is when people are not having relapses or active enhancing lesions on MRI. Evobrutinib is another BTK which is being looked at in relapsing remitting MS, and that's been a clinical trial here at Ohio Health that Dr. Andy Smith has run as the principal investigator. And again, we're excited to see some of the long-term results. And then lastly, orelabrutinib, I love saying these names, is currently in phase 2 studies, and that's being looked at in relapsing MS and active SPMS. So more to come. You will hear more about these in time. I wanted to run you through the phase 2 clinical trial of Tolebrutinib, one of the BTK inhibitors, which is actually already published. And data was reviewed and presented at our most recent American Committee for the Treatment of MS just this past few months here. So in this study, I'll actually jump to the next slide because that may help to explain it. There were about 130 patients, and they were randomized into one of two groups. So in group 1, those individuals actually received the study treatment, which was an oral pill, Tolebrutinib, for 12 weeks. And then they stopped that and they did 4 weeks of a placebo pill. Group 2 received placebo for 4 weeks, and then they received Tolebrutinib for the following 12 weeks. What was looked at as the endpoint to measure how well this worked was whether or not people had new active, what we call enhancing lesions with contrast on MRI after the 12 weeks of treatment. What we found, if you look here on the right-hand side, is that there was a dose-dependent decrease in new enhancing lesions. So it really looked like this 60 milligram dose was highly effective at preventing new inflammation in the brain on MRI in these patients. Overall, the treatment was well tolerated and safe. The most common side effect that was noted was headache in about 7% of patients while on Tolebrutinib. There's an extension study that has been done as well, and this included 122 of the original 130 patients in the phase 2 study. They all received the 60 milligram dose, and you can see here that the results were very impressive. So close to 90% were relapse-free, and the mean EDSS, which is a number score we give based on your physical examination or your neurologic exam, for the patients on 60 milligrams actually remained stable. And again, the most common side effects were actually similar in the extension study. We did see headache in about 10%. Certainly the timing of the trial, we saw 9% of patients with COVID-19, upper respiratory infection, and nasopharyngitis. I wanted to jump in and talk a little bit about stem cell therapy. The reason I'm bringing this up is because the National MS Society actually updated guidelines for MS specialized neurologists to consider discussing this with a subset of patients who may need this therapy. So autologous hematopoietic stem cell transplantation is one type of stem cell transplant. When an individual undergoes this therapy, they actually receive a medication to help release their stem cells from the bone marrow into the bloodstream. Then those cells are actually collected from the bloodstream via blood draws, and that blood is stored in a laboratory. Following that, patients who are undergoing this procedure then actually receive chemotherapy to suppress their immune system. And then once their immune system has been suppressed, they actually then receive those same blood stem cells that were removed from the body back in through their vein. And then they're continued to undergo close medical follow-up and treatment. Typically, when a patient undergoes this process, it is very intense, and it requires about a 3-week hospital admission because the immune system is almost non-existent following the point of receiving chemotherapy. So it does have a lot of risks, but certainly we know it has great benefits. This is what I think is exciting, is that the National MS Society has come to the consensus that there is a very small group of patients in MS that we should be considering this potentially, even at this point in time. These would be people who have relapsing remitting MS, who are earlier in the course of their disease, so people who are under the age of 50, people who have not had MS for over 10 years, and the very key thing here is that people who are breaking through or having new lesions and new relapses despite use of what we call high efficacy therapy. And so these therapies would be treatments like alemtuzumab or Lemtrada, natalizumab or Tysabri, ocrelizumab or Ocrevus, ofatumumab, which is Kesimpta, or rituximab. Some neurologists may consider cladribine to be part of this group, and that's a medicine called Mavenclad. Again, this will be few and far between patients that are recommended to receive this, because traditionally our treatments that are available will be able to control MS. But again, it is something that is very new and out from the National MS Society. One thing that I want to caution you about is that this treatment, even though it is highly effective, does have a lot of risks. The exciting news is there is an enrolling trial happening in the United States looking at this type of stem cell treatment, and it's called Beat MS. And individuals that qualify would be people who are already on highly effective therapy, but who are breaking through. Patients in this study would be randomized to receiving either the stem cell therapy or going on a highly effective therapy, and they don't have the choice in what they go on. It's very important that if you are thinking about stem cells or you're looking into this, that you do not just go to any place. There are lots of sham stem cell centers out there where unfortunately people may be trying to take advantage of you or take your money. Fortunately, there is an organization called FACT, which is an accredited cell therapies organization, and you can actually go to this website and search and find out where approved centers are within the United States and the world. And so I highly encourage that, because I have seen people get hurt financially or physically from going to places that are not approved. But again, this is really for a select group of patients with MS. Briefly, I know I'm going slightly over, I want to mention to you something about Nanocrystalline Gold. So this is actually an oral therapy that was initially studied in animal models of MS, and now interim data from phase 2 studies in humans with multiple sclerosis is available. This trial is called Visionary MS, and these individuals were given nanocrystalline gold, which they refer to as the CNMAU8, and they're looking at it in people who have MS and a history of prior optic neuritis. What they're looking at is whether or not this can remyelinate and repair damaged neurons in MS, and it's been studied in people, again, with stable MS on DMT with chronic optic nerve damage. What they're looking at is really to see if their vision improves. And the preliminary data has come out showing that there actually have been improvements on a series of tests called the MS Functional Composite, which really looks not only at vision, but also at cognition and upper limb function, as well as gait. It's important to note this is an unblinded study, so sometimes that can taint the results, but I'm excited to continue to see more, as this was just presented within the past month. Lastly, wearing off of ocrelizumab. Many of you out there who are on ocrelizumab may have already told your doctor or your nurse practitioner that you don't feel good. People even say it's called the crap gap, where they feel like that month or a couple weeks before their next infusion of Ocrevus, they just feel horrible. It's not one specific thing. It's mostly fatigue, but it could be worsening of many of their chronic MS symptoms. So there was a really neat study that was done by Tarup et al. And published in the Multiple Sclerosis and Related Disease Disorders Journal in the past several months. It looked at 117 individuals with MS on ocrelizumab for over a year. 61% of them stated that they were having a wearing off effect in terms of just how they felt symptomatically. The majority of them were people who reported it between 1 to 4 weeks prior to their next infusion, but there were people who reported it even greater than 4 weeks. Most of them, 44%, said that it resolved within 1 week of receiving their next ocrelizumab dose. What this study showed is that people who had a higher BMI, so higher body mass index, were at an increased risk of wearing off by about 2.7 times those of people who had lower BMIs, so people who weighed less. Interestingly, when they looked at neurologic exam scale scores, their B cells, which is what Ocrevus is doing, is it's depleting B cells. Even the fact that those were not returning really had nothing to do with these symptoms. So this is something that's continuing to be looked at, but definitely you're not alone if you're experiencing those symptoms. So I've taken a little more time than I should.